Module Overview. Communication is more than just conveying information. It is the bedrock of compassionate, ethical, and effective palliative care. In the emotionally charged landscape of terminal illness and dying, how information is shared can either build trust, foster peace, and empower decision-making, or cause confusion, distress, and emotional harm. This module equips you with the advanced skills needed to communicate sensitively, truthfully, and supportively with patients, families, and interdisciplinary care teams. It explores structured approaches to breaking bad news, active listening, cultural communication patterns, managing silence, and handling difficult conversations such as prognostic discussions, care goals, and Do Not Resuscitate DNR orders. You will be able to adapt their communication style to various situations, including progressive cognitive decline, pediatric palliative care, and dealing with emotionally overwhelmed or resistant family members. This module meets international standards, including those outlined by the World Health Organization, WHO, American Academy of Hospice and Palliative Medicine, AAHPM, and the National Consensus Project Clinical Practice Guidelines. Learning Objectives. By the end of this module, you will be able to explain the importance of clear, compassionate communication in palliative care. Apply structured communication models, including spikes, NURSE, and ABCDE in clinical practice. Deliver bad news truthfully while preserving hope and emotional safety. Manage emotional responses such as denial, anger, silence, or overwhelm. Engage in goals of care and advance directive conversations confidently. Recognize cultural and religious nuances in end-of-life communication. Practice active listening, reflective empathy, and nonverbal communication. Prepare documentation and coordinate care based on communicated wishes. Section 1. The role of communication in palliative care. Communication is not a one-time act. It is a continuum of dialogue across the illness trajectory. Effective communication enhances patient dignity and trust, reduces anxiety and suffering, prevents unwanted interventions, improves family satisfaction, strengthens interdisciplinary collaboration. Section 2. Challenges in end-of-life communication. Common challenges include uncertainty about prognosis, fear of taking away hope, cultural taboos around death, family disagreements about what the patient should know, clinician discomfort or lack of training, time pressures in acute settings. Many patients want truthfulness, clarity, and a sense of control, even if the news is difficult. Section 3. Structured communication models. Spikes model, for breaking bad news. S. Setting up the interview, privacy, family present, no interruptions. P. Assessing the patient's perception. What do you understand about your illness? I. Invitation to share information. Would you like me to explain the results? K. Knowledge. Give information in chunks, avoid jargon. E. Explore emotions with empathy, e.g., I can see this is very upsetting. S. Strategy and summary. Next steps, follow-up plan. Nurse technique, responding to emotions. N. Name the emotion. You seem angry. U. Understand it. This is a difficult time. R. Respect it. I admire your courage. S. Support it. We are here with you. E. Explore it. Can you tell me more? A, B, C, D, E for difficult conversations. A. Advanced preparation. B. Build a therapeutic environment. C. Communicate well. D. Deal with reactions. E. Encourage and empathize. Section 4. Techniques for effective dialogue. Use clear, slow, jargon-free language. Sit down. Maintain gentle eye contact. Silence is powerful. Don't rush it. Use reflective phrases. It sounds like, you're wondering if. Avoid false reassurance. Everything will be fine. Avoid medical overload without context. Section 5. Cultural and religious sensitivity in communication. Different cultures have varying attitudes toward disclosure of diagnosis or prognosis, individual versus family decision-making, death rituals and spiritual interpretations, role of the physician or spiritual leaders, expression of grief and emotion. Key strategy: ask open-ended questions about beliefs. How do you and your family like to receive medical information? Is there someone else we should include in these conversations? Section 6. Pediatric and geriatric communication. In children, use developmentally appropriate language. In elderly patients with dementia or sensory loss, simplify and repeat, include caregivers, but prioritize patient autonomy where possible. Section 7. Goals of care and advanced care planning. These conversations are not just medical, they are deeply personal and value-driven. Key elements: clarify what matters most to the patient, discuss likely outcomes and treatment burdens, introduce DNR, advanced directives, living wills, POL-ST, frame choices around comfort versus prolongation of life. Avoid, do you want everything done? Use, if your heart stopped, would you want us to try CPR, knowing it may not be successful and may cause harm? Section 8. Involving family and team in communication. Use family meetings for complex updates or conflicts. Designate a family spokesperson if helpful. Document decisions clearly, foster collaborative decision-making between patient, family, and team. Section 9. Documentation and communication handover. Clearly document prognostic conversations, advanced directives and goals of care, patient preferences, e.g., home death, family discussions and agreements, ensure communication across shifts and settings, e.g., from hospital to hospice. Module summary. Module 7 empowers you with the human connection tools vital to palliative care. Communication is not just a skill, it is an act of presence, empathy, and healing. By mastering structured methods, cultural competence, and emotional intelligence, healthcare professionals can navigate complex conversations with grace, sensitivity, and clarity, ensuring patients and families feel heard, respected, and empowered, even in the face of devastating realities.